The Springfield Project was discussed at a Greater Springfield Chamber of Commerce legislative breakfast on May 20th, 2010. The project is based on a model first tried in Asheville, North Carolina that was an effort to bring down health care costs. It has now been tried in 80 communities and has been successful in bringing down costs and improving patients' health everywhere it has been tried. The Chamber and the Cedarville University School of Pharmacy are bringing the program to Springfield employers who wish to take part.
I'll tell you a little bit about some sobering facts. Adverse drug reactions are actually the fourth leading cause of death in the United States. And the estimated cost of adverse drug reactions in the United States is $136 billion a year. And that is billion with a B. Now, non-adherence, patients who don't take the medications properly for one reason or another, 15 to 20% of prescriptions never get filled in the first place. And that is lost therapy. 33 to 69%, as much as almost 70% of accounts for all medication-related hospital admissions in the U.S. And the estimated cost is $290 billion a year, or 13% of all healthcare expenditures. All the way back in 1994, there was a group of pharmacists who got together in North Carolina and looked at this picture of adverse drug reactions and non-adherence and misprescribing and said, we ought to do something about this. What can we do? So they formed a coalition of groups, a joint effort between different pharmacy groups, Campbell University, University of North Carolina, the pharmaceutical industry, hospitals, pharmacy networks, and they proposed a demonstration project. They worked 2 years to identify self-insured employers, develop outcome parameters, set up training schedules for pharmacists so that pharmacists could work on this picture of adverse drug reactions and non-adherence and do something about it. They approached the city manager, the benefit manager for the city of Asheville, and proposed the project in Asheville. And they talked with physicians in Asheville to review the proposal, to make sure that physicians, primary care providers, would be on board with it. So, to summarize the model very briefly, intense self-care education is provided by pharmacists and other mid-level professionals to patients who need it. There is frequent face-to-face follow-up by a personal health coach. In this case, concerning medications, these would be specially trained community pharmacists. So the basic practice model was they formed a tighter partnership between the pharmacist, the primary care provider, and the patient, where all three were sharing information about the care of the patient with each other. Employers encourage participation, medications are taken as prescribed, and adverse effects are caught before the patient ends up in the hospital with them. The Asheville Project saved money on the healthcare system of Asheville, saved money for the employers of Asheville. But it would be meaningless if it didn't also improve the health of the patients. After 8 years of the program, there were no diabetic patients who were put on dialysis. No diabetic patients that needed a kidney transplant. And dialysis and transplants are expensive. For asthma, there was a 50% reduction in the number of patients who had severe asthma. There were a more than 3 times reduction in the number of hospitalizations. Missed work due to asthma decreased by 400%. And a net decrease in total healthcare costs of $725 per patient per year for patients with asthma. Looking at cardiovascular health, after 8 years of the program, there were 1.7 times more patients who were at goal blood pressure, 1.5 times more patients who were at goal cholesterol levels, and a nearly 50% reduction in the number of heart attacks, strokes, and other cardiovascular events.